Hello, everyone. Welcome to the Pain Management and Sickle Cell Disease session. My name is Dapo. I'm one of the technical leads from Taskoff Global Consulting that is providing technical support for the Congress. And today, it's my pleasure to introduce the moderator for the session, Dr. Adekunle Adekile. Dr. Adekile is a professor in the Department of Pediatrics, Faculty of Medicine at Kuwait University. He is the Chief of Pediatric Hematology at Mubarak Hospital, where he looks after patients with sickle cell disease, thalassemia, and other benign hematology disorders. He's the director of the Kuwait National Sickle Cell Registry, which he established in 2011. He is active in the hematology professional circles in the Arabian Gulf. He was in Howard University Hospital in Washington, D.C. from 1980 to 1981 for his postdoctoral fellowship in pediatric hematology, during which time he worked at the Comprehensive Sickle Cell Center under Dr. Roland Scott. He has served as a consultant to the World Health Organization / AFRO on the management of sickle cell disease in Africa. He is the current editor-in-chief of Hemoglobin, the International Journal of Hemoglobin Research. Welcome, Dr. Adekunle, and I'll leave it to you.
Well, thank you very much, Dapo, for the introduction. And it's my pleasure to moderate this very important session. And I welcome all the attendees. As we all know, those of us who look after sickle cell patients anywhere in the world, that what brings them to the hospital most of the time is pain episode, which can be very distressing, as you can imagine. And we always want to give them relief as soon as possible. And that's why it's so important to be aware of what interventions are necessary and prudent. Unfortunately, some patients would also develop chronic pain, which is a little different from acute pain. So we need to be aware of all the possibilities. We are fortunate to have two excellent speakers this afternoon. The first speaker is Dr. Andrea Cervi, who is an adult hematologist practicing at the Windsor Regional Hospital in Windsor, Ontario, where she serves as the division head of the thrombosis department. She obtained her master's in science in biochemical and molecular sciences at Queen's University, followed by her MD at the University of Tours and internal medicine at the hematology training at McMaster University. Dr. Cervi has a mixed malignant and non-malignant hematology practice based entirely at the Windsor Regional Cancer Program. So you're most welcome, Andrea. Please take it on, and I'll give you a warning when it's 2 minutes to your allocated time.
Thank you so very much, Dr. Adekile, for the introduction, and thank you to Gansett and the Congress for the opportunity to present on this very important topic. So as an introduction, I'll be speaking on the effective management of acute or episodic pain in sickle cell disease. As a bit of background, we know that pain, unfortunately, is the most common complication of sickle cell disease, and that pain can arise for a number of different mechanisms, often which it sort of circulates around the provision or the circulation of sickled red cells through the vasculature, which can lead to hemolysis. It can lead to tissue injury, ischemia, reperfusion injuries. It can be quite damaging to the local endothelium and vasculature, and it can cause vaso-occlusion. And through this process, that can create a very sort of noxious pro-inflammatory microenvironment that can then lead to the signaling and activation of pain fibers within the peripheral organ systems that then travel through the spinal cord to higher elements of the brain where pain is then perceived. Throughout this realization of this sort of pro-inflammatory microenvironment, there's been recognition of different cellular and molecular mediators of various elements of inflammation that can contribute to pain perception. And these have been studied in various ways as possible targets for pain control in sickle cell disease, because again, these mediators can then directly activate neurons within the peripheral nervous system that do travel through the spinal cord to higher parts of the brain where, again, pain perception is actually taking place. Studies, or rather efforts to study pain perception in sickle cell disease have demonstrated that this is quite prevalent in both an acute setting along with a chronic setting, as Dr. Adekile had mentioned. So one particular study identified that among adults with sickle cell disease, 50% reported experiencing pain more than 3 days per week, and that 40% of patients actually take some form of pain medication on a daily basis. Despite this, 30% of people will still report having daily pain. While we can sort of focus on the sort of inflammatory environment that sickled red cells can contribute to and how that can lead to pain perception, we know that in sickle cell disease, the perception of pain is more complex and more multidisciplinary than just ischemia alone. So there's an element of sort of psychosocial distress that can lead to pain perception through depression and anxiety. Sleep deprivation can contribute to pain perception. And then for different reasons, we can actually have sensitization of the nervous system among some people with sickle cell disease that can lead to sort of this neuropathic or hyperanalgesia, which again can contribute to the idea of pain. Pain in sickle cell disease can also take on different tempos and different patterns. And so, we do focus a lot on sort of acute episodic pain, as that's often the pain that drives people to coming to the emergency room in acute care setting. But there's also chronic daily pain, and there can be acute exacerbations of that chronic daily pain, all of which can contribute to a reduction in quality of life. We recognize that pain in sickle cell disease also spans the life ages. So it can start as early as 1 year of age and be quite pervasive and persist throughout different stages of adulthood as well. The ideal way to address pain in sickle cell disease really does rest on integration of both pharmacologic and non-pharmacologic therapies. And this really should be undertaken in a very individualized, patient-centered, multidisciplinary fashion. So not one pain management strategy will fit all people with sickle cell disease. We really do need to be working with our patients to develop individualized pain strategies. Generally speaking, though, opioids do oftentimes become integrated upfront in addressing acute episodic pain in a more acute care setting. And if we look at the relatively recent American Society of Hematology guidelines that were published in 2020 on how we sort of address acute and chronic pain, the first recommendation is that for all adults and children with sickle cell disease presenting to an acute care setting with pain felt to be related to sickle cell disease, we should be promoting the rapid administration of pain medication with very frequent reassessments to optimize pain control. And ultimately, the panel that was responsible for these guidelines felt that the benefits outweighed the harms in terms of the rapid administration of opioids. So opioids can exert analgesia or pain relief through a number of different mechanisms. And this little graphic here is likely a bit oversimplified, but generally they can work at 3 parts of the pain pathway. Through opioids binding to receptors in the periphery, where there's those pain sensing fibers, they can actually block their activation. So when they would otherwise be activated in that sort of very noxious pro-inflammatory microenvironment, opioids can sort of sift in and block the activation there. They can also act through different receptors present throughout the spinal cord, where some pain fibers would then signal to sort of further promote that messaging of pain to the brain. So opioids do have a role at the level of the spinal cord, and then they can work at higher levels within the brain to, again, reduce that sort of perception of pain. There are different ways to administer opioids, and the effect that an opioid has does depend on how it enters the body. And so opioids taken by mouth and generally take a bit longer to exert their effect because they do warrant first pass metabolism through the liver before their metabolites can become active and act at those different pathways that we just outlined. Opioids taken in through the intravenous system actually directly enter the bloodstream, and so that's how they tend to have a quicker, more immediate effect. When we look at how intravenous opioids can be delivered, there's different methods there as well. So there's PCA, or patient-controlled analgesia, where patients are allowed to sort of self-administer a small amount of opioid that would be prescribed by the physician in charge of this, often in anesthesia, but not necessarily always. And then they can sort of monitor the amount of pain medication that's warranted in a certain period of time. And this would be used with certain opioids like morphine or hydromorphone or even fentanyl. This is just another sort of pictorial demographic here using mainly fentanyl, where you can see the remote control. And sometimes the sort of patient-delivered bolus is mixed actually with a basal infusion rate as well, depending on the center's expertise and access to these sorts of modalities. There's also probably more commonly, at least in our center, would be intermittent clinician boluses, where the clinicians are actually prescribing a dose and how frequent that dose of opioid can be delivered, or continuous infusions. But typically that would require a higher level of monitoring setting to ensure that we're closely looking for any possible complications, particularly sedating and respiratory effect of opioids. More in terms of additional pharmacologic ways to address acute or episodic pain would be pairing opioids with adjunct therapies. And one that's become a little bit more prevalent within the guidelines and the literature is use of the non-steroidal anti-inflammatory drugs, or NSAIDs. So NSAIDs through different mechanisms can sort of block activation of the COX pathways, which has later effects on prostaglandin signaling. And these can be very, very useful adjuncts to opioids in an acute pain situation. Some agents would be things like diclofenac or ibuprofen, or more selective inhibitors like celecoxib. But it does need to be underscored that this would be considered a more short-term sort of adjunct to opioid therapy, because there are some cumulative risks, particularly in terms of bleeding and vasoconstriction within the kidneys, which can lead to some acute kidney injury, and irritation of the gastric mucosa, which can lend itself towards peptic ulcer disease. So good in an upfront and adjunct setting, but something that does need to be frequently reevaluated and not considered long-term in terms of a heavier use. In the event that opioids were to fail or be ineffective, there are other options in the form of regional anesthesia, or possibly even sub-anesthetic ketamine infusions. But that would really rely upon the center if they had sort of protocols in place and they had the appropriate expertise. And then, although we don't typically think of intravenous fluids as necessarily pharmacologic agents of pain control, there has been some literature looking at the use of IV fluids to potentially assist in this sort of acute pain setting, because it can cause a little bit of vasodilution of some of the accumulation or occlusion that's happening from circulation of the sickled red blood cells. But really, although we speak about pharmacologic therapy, on the one hand, it really does need to be integrated with non-pharmacologic modalities, which also have a good effect for pain control and can supplement the pharmacologic element as well. So psychologic principles like cognitive behavioral therapy, certain types of physical therapies like massage, yoga, or audiovisual redirection, social therapy, peer support, and group therapy, and another category labeled as alternative foundations, practicing through prayer or acceptance-based therapies as well. And ideally, both of these elements of pharmacologic and non-pharmacologic are integrated again into a patient-specific and specifically tailored pain pathway. I do also want to emphasize that we should be striving towards managing acute or episodic pain in sickle cell disease in a sickle cell disease specific acute treatment facility, where patients are not necessarily subject to wait times within the emergency room, although we are striving to really minimize that for our patients. But if we had sort of medical daycares or infusion centers where we could more rapidly direct patients to get more targeted care, that would really be the goal, and that is integrated into more recent guidelines and more evolving literature saying that we really should be having a dedicated acute care specific facility to address the complex pain of sickle cell disease. So to summarize, a lot of these concepts, I will say that opioid therapy is again not a one size fits all type of approach, and due to differences in genetic polymorphism, some patients with sickle cell disease may not necessarily metabolize opioids in the same way, and that can lead to variable effectiveness and efficacy of opioids in analgesia, and it can also lend itself to specific side effects and complications as well. And while we know that the guidelines are still supporting use of opioids for the management of acute pain, details relating to the type of opioid, the mode of administration, the frequency do remain poorly studied. And I think that does speak to the fact that, again, we do need to have more patient tailored approaches. We also really need to be considering non-opioid adjuncts like NSAIDs for comprehensive pain control, along with non-pharmacologic modalities. Again, thinking about physical therapy and group support and peer support. And we should be striving to manage these acute pain episodes in an individualized, patient-centered fashion that takes place within a facility that's more geared towards pain management for sickle cell disease. So with that, I thank you so much for your time and attention, and I'll stop sharing my slides at this time.
Well, thank you very much for that comprehensive and enlightening presentation. I think you saved us some time. I think if we have any questions, please put it in the chat box or the Q&A. There isn't any right now, but if since we have some time, let me ask. Now, you mentioned about non-steroidal anti-inflammatories. Now, what is the role of intravenous administration, and which preparations can be used in that way, and what are the considerations?
Thank you, Dr. Adekile, for that question. At our center, we often recommend for use of IV ketorolac. That's probably the most widely available intravenous intravenous form of nonsteroidal anti-inflammatory drug that we have access to, and we do have order sets to guide physicians both in the emergency department and in the internal medicine and the inpatient side of things that would recommend that gets reevaluated after 72 hours, again, so that we do avoid those possible side effects and toxicities.
Well, thank you. I don't see any other question right now, so we'll go to the next speaker. Now, Dr. Jennifer Bryan is an emergency physician and emergency research director at the University Health Network. She's an associate professor at the University of Toronto. She led the inaugural national recommendations on addressing racism and colonialism in emergency medicine. She champions equity as chair of the Canadian Association of Emergency Physicians Anti-Racism and Anti-Colonialism Committee. Dr. Bryan founded and chairs the UHN Emergency Department Sickle Cell Working Group, recognized nationally for their work in advancing timely pain relief for patients with sickle cell disease. You're welcome, Jennifer. Please take it on.
Thank you so much, Dr. Adekile. And thank you, Dr. Cervi. I'm glad that we have the opportunity to speak together today. And I'm grateful to the organizers of GANSID for the invitation. Dr. Cervi gave a fantastic overview of pain management options. I'm going to add to that by speaking a little bit more specifically about the emergency department setting and pain options there. So what I'm I'm not going to be going over is a focus on pediatrics. My work is mainly in the adult space, but most of the things that I'm going to be talking about will apply to those of you who are working with the little people as well. I'm not going to be focusing on prevention. There were some excellent talks earlier today talking about routine management of sickle cell and especially the role of hydroxyurea. I won't be going over that in this session. And like Dr. Cervi said, emergency department care for sickle cell is not the ideal setting. So ideally, we would have acute care treatment centers dedicated for sickle cell. But as that is still not the reality in most areas, it's important that we optimize emergency department care. So what I will be going over is something about the current state in emergency medicine, barriers and opportunities, some practical strategies for pain management, and presenting each of you with a challenge at the end of my session. This is a quote from the late painter Hertz Nazaire. Hertz Nazaire lived with sickle cell disease and used art as a way of educating about sickle cell. And he said, the doctors simply did not believe my pain was real. And this is something that I've heard again and again from people living with sickle cell disease, that there are barriers in terms of understanding pain in sickle cell that interfere with people being able to get high quality care. Dr. Cervi showed the recommendations from ASH around the timing for pain medications in emergency department settings. These are the guidelines that are in use in my province in Ontario, in Canada, very similar. So the ASH guidelines are to start analgesia within 60 minutes of presentation. That's the same for us. And then with the additional detail, that treatment should begin within 30 minutes of triage. Now, in my center, we have the largest red blood cell disorders clinic in North America. We should be able to provide excellent emergency department care for patients living with sickle cell. But when we looked at our data in 2019, we saw that we weren't doing a very good job. 5.6% of people were receiving their pain medication within the targeted 30 minutes, but 94.4% of people were waiting longer than the recommended time. We've done a lot of work in our department to try to improve this. And at last check, so in September of this year, 50% of people living with sickle cell who came to our emergency department were receiving their pain medication within 30 minutes. So we're not at the 100% that we need to be, but we are getting closer and closer every month. Now, let's talk about some of the barriers to care. So why aren't all patients who present to emergency settings getting rapid, appropriate pain medications? There are really 4 reasons that I'd like to go over. So one is that there are some universal access issues in terms of overcrowding, underfunding of emergency department care. But there are some other specific barriers for people living with sickle cell, and that includes barriers related to the opioid epidemic, to the realities of racism in healthcare, and to our misunderstandings and miseducation related to how we assess pain. And I want to dive into that last one. So we misunderstand what pain looks like. We think of people in pain as being in tears, as crying out, as rolling around on the floor, but we know that that's not how everybody presents in pain, particularly people who have a lifetime of expertise and unfortunate experience in living with pain. So like Dr. Andrea Cervi mentioned, for patients who have had symptoms of sickle cell disease, since they were, less than a year old, a lifetime of pain in an acute pain flare can look very different. We have a number of tools at our disposal to try to quantify pain, which are important to use mainly because they're a reminder for us to ask about pain regularly. This is an example of a Likert scale type assessment for pain, where you ask a patient from 0 to 10, where is your pain right now? These assessments can be very helpful to compare within a specific person if their pain is getting better, if their pain is getting worse, but not between patients. So a 10 out of 10 pain is going to mean a very different thing for one person than for another. And the take home from this is that really the only way to tell how much pain someone is having is to ask them. And I would add to this to ask them and to believe what they tell you. Sickle cell disease, pain episodes, they don't come along with changes in vital signs. They don't come along with changes in blood values or X-ray findings. And people living with sickle cell are often accused of being drug seekers, of trying to get opioids for reasons other than pain management. People living with sickle cell disease often have frequent hospital visits, often have a number of different prescribers for pain medications, and may request a specific name and dose of medications. These are all things that in the health professions we get taught are signs of opioid misuse. But what we are not often taught is that these are also signs of someone who has inadequate pain management. So if you are living with extreme pain and you are not getting the care that you need at one center, of course you're going to try somewhere else. Of course you're going to end up having multiple different visits and different prescribers. And of course you're going to tell your provider exactly what it is that you need in terms of which pain medication works for you, how much, and you're going to hope that they believe you and listen. This is data from a number of years back in the United States, where emergency healthcare providers were asked how common they thought opioid use disorder was in people living with sickle cell. And healthcare providers estimated about 20% of people, or 1 in 5 of the patients that they were seeing with sickle cell, were using opioids inappropriately. The reality is that the number is less than 2% of people living with sickle cell that have issues with opioid use disorder. And this is on par with other patient populations who require opioids for pain. This is summarized very well by my colleague, Dr. Hassan Sheikh, who works with me at the University Health Network in Toronto, Canada, and who is a nationally recognized expert in addictions medicine. And he says, yes, there is an opioid crisis, but it's not being driven by patients with sickle cell. So we need to be taking pain related to sickle cell disease seriously as we take oncologic pain. I see very few people hesitating to give pain medications for patients that are living with pancreatic CA, for example. And we need to take pain from sickle cell disease as seriously. The emergency department management of pain related to sickle cell disease does not need to be complicated. It can be very, very straightforward. But there are some important steps to take and to ensure that we're able to provide high quality care. And these are really the 5 components that go into improved patient outcomes and provider satisfaction. Healthcare providers are happier, more satisfied with their care when they're able to provide high quality care, when they're taking great care of patients, because that's what we all want to be doing. So we need to look at opportunities for education. We need an interdisciplinary approach. These initiatives need to be patient-led. We need to use standard procedures and have clear metrics and recognize when things are going well. There are a number of great resources for healthcare professional education. This is one. This is through the Sickle Cell Awareness Group of Ontario, a online a series of education sessions for healthcare professionals. You can certainly look at resources that are available in your own area as well. Interdisciplinary care, I cannot overstate how important that is to providing high quality sickle cell disease care. This is a diagram showing the many groups that are part of the working team that we have in my emergency department to advance sickle cell care. We have MDs, we have nurses, we have social workers, we have allied health members, and most importantly, I think, is our patient experience advocates. So the sickle cell warriors and community advocacy group representatives who are such a core part of this work and really guide us every step of the way. This is a phrase that came up at previous talks today, nothing about us without us, that comes from a disability advocacy. And this really underpins any successful intervention that I've seen related to sickle cell, is that it very much centers the voices of patients. In this photo on the screen, you can see sickle cell warrior Serena Thompson, and standing beside her, nurse Ruth Appiah Boateng. These were in the early days of COVID, still giving education sessions in our emergency department to ensure that that our nurses and physicians and allied health workers were hearing patient stories and were getting reminded of the importance of providing high quality care. Dr. Cervi mentioned about using an order set to standardize care, and this has been very helpful in our department. Our order set was co-designed with patients. It includes tips around assessment, investigations, treatments, to try to ensure that there's consistency in care, so that every time someone comes into the emergency department, that they are more likely to get high quality care independent of who happens to be sitting at the triage desk or who happens to sign up as their physician that day. Very important to recognize and celebrate successes. We talk a lot about barriers, we talk a lot about gaps in care, but looking to see when things are going well. Who are the champions in your team? Who are the people who should be held up as role models that the other people that you're collaborating with can continue to learn from? So celebrating those successes is important. I'm going to talk a little bit about pain management strategies. Dr. Cervi did an excellent job in going into detail on this, so I'm going to go through this very briefly, but again, emphasizing the importance of non-pharmacologic strategies paired with opioids, and a little bit about what's new in the literature. For non-pharmacologic strategies, acutely, there are a number of great options. I've got the blanket there to symbolize warmth, so avoiding ice packs, using hot packs, using warm blankets. Distraction is incredibly important. Lots of people in my emergency department asked to use chargers for their phones, for their computers. I consider that a health intervention for patients with sickle cell. So distraction is an incredibly important pain relief strategy. Strategies like training in cognitive behavioral therapy are very important. Sometimes people hear discussions around psychological strategies for pain management, cognitive behavioral therapy as discounting the reality of pain, and that's not at all the case. These are incredibly important strategies for the active management of pain and can be very empowering for patients. And then finally, on the right side of the screen, an image to represent the importance of comfort and support from friends and family. So this is included in our order set, the importance of having somebody at bedside if at all possible. So I encourage people who come in on their own to call friends, to call family, to have that emotional support that goes beyond what we're able to provide as healthcare providers. Dr. Cervi did a great job in talking about the non-opioids, and another plug for remembering that these work synergistically with opioids as well, and can allow treatments to be opioid sparing at times. So using appropriate dosing of acetaminophen, ibuprofen can help to decrease the doses needed for opioids and the frequency of dosing. A quick reminder around the fact that despite the route of administration, the duration of analgesia is very similar, whether you're using parenteral opioids, whether you're using oral opioids. These are the options that are most commonly used in my setting. So morphine, hydromorphone. We are very fortunate that we have the option of sublingual fentanyl. We use that if we're not able to get easy IV access, which is often a challenge. So that can buy us some time. So give people some rapid pain relief while we're trying to secure IV access. Dr. Cervi mentioned about PCA. There are also settings that use nitrous and other inhaled methods for analgesia. It's not something that we have access to in my center, but maybe something to explore depending on what's available at your center. Reminder, of course, about opioid risks. So we monitor our patients closely. We don't want to run into issues around opioid respiratory suppression. We know that opioids cause nausea, vomiting, pruritus, so you need to have a plan about managing each of those potential complications. If somebody is leaving the emergency department after receiving opioids, you need to have a plan around preventing constipation and a safety plan around somnolence. So explicit instructions to not drive, to not be the person in charge of an underage minor or a vulnerable elderly person. So someone who is taking opioids needs to have some kind of a shared plan in place for how to manage if they're not able to do things that need their full attention. Very briefly about a couple of things that are new-ish. I say new-ish because they've been around for the management of pain in other conditions. Dr. Cervi mentioned ketamine. We use ketamine in my department in sub-dissociative doses for analgesia. And we've recently had approval for our department to begin giving that as an infusion over a short period of time from the nurses. We generally start off again for adults between 0.1 to 0.3 milligrams per kilogram as a bolus, or infused over a half hour to an hour. Regional nerve blocks, which Dr. Cervi mentioned, are a great option, especially if your department members have training in point of care ultrasound. Regional nerve blocks and peripheral nerve blocks, especially for extremity isolated pain in sickle cell, can offer great relief. Now, to wrap up, I want to pose a challenge to everyone who is listening today, and that's to go back to your work settings and identify and tackle the barriers that are present. So the barriers may be quite different setting to setting, and so identifying within your context, what are the things that are interfering with your healthcare providers being able to give the great care that they want to be able to give. Using clinical research to shape better care, and that may look at keeping up on the latest data that's available in the literature. It may also look like finding ways that your center may contribute to the existing body of knowledge. So taking on research, participating in some of the multi-site trials, it can make a huge difference in options for patients down the road. And a reminder to celebrate high quality care. There are a lot of things that we still need to work on and that need to be done. But it's important along the way to celebrate the wins, celebrate the successes. In the emergency department, we have the opportunity to make a difference for patients who are living with sickle cell disease. And by working together, we can make emergency departments what the late painter Hertz Nazaire hoped for: a place where he could find a fragment of peace in a storm of pain. Thank you so much.
Well, thank you so much, Jennifer, for that very lucid presentation and, very enlightening and reassuring. And I'm so happy that you addressed the question of the issue of labeling patients as drug seekers, because that's one of the biggest stigmas that we encounter when we look after sickle cell patients with pain. And it's again reassuring that there's really no evidence that sickle cell disease patients are contributing to the abuse that is rampant with opioids. Thank you. Now, there have been some questions in the Q&A box, and Andrea has addressed some of them. One is the question of this, central line, and if there are issues. And of course, she has said that, central lines pose an increased risk for infection and thrombosis because there's always some, risk of damage to the lining of the blood vessel. So that's why, we don't go into that, lightly, and it's done under supervision. Then the question of NSAIDs and the complication from excessive use. And of course, she mentioned there that excessive use can be detrimental, especially to the kidneys because of the vasoconstriction that is associated with the use. But quite often we use them anyway, for a short term. What we don't like to see is chronic use of NSAIDs.
And
Now,
Dr. Adkile, if I could
yes,
just
please.
add in there. In parallel with the literature on pain management in sickle cell, there's some really great literature on NSAIDs in elderly patients. And one of the things that I gleaned from that literature is that there's a cost benefit analysis that needs to be done with NSAIDs. And so certainly NSAIDs are not without risk, but if a short-term use of NSAID can save you having to use higher dose opioids or more frequent opioids, on balance, that may be a benefit that's important for your patient. So doing that cost benefit analysis is important.
Very good. Yeah, so true. Now, let me ask one question. Now, now and again, we have patients who come with very bad vaso-occlusive crisis and severe pain, and you've had them in the ward for a couple of days on very high doses of opioids, and they're still in pain, and you've ruled out other complications like osteomyelitis or avascular necrosis. At that point, what are your other options? People have thought of, whether you should give blood transfusion, steroids, or whatever. Now, what would you, either of you, say about that? What are the options?
So I can start off, but I'll certainly turn things over to Dr. Cervi. My work is really in the acute care setting. And so for me, if I'm not able to get good pain management, and good pain management is that person in front of me feeling like they're going to be able to get home safe. Like that's the definition of good pain management for me. If I'm not able to get good pain management, then I'm phoning a friend. I'm calling the internal medicine specialist. I'm reaching out to the other consultants in my hospital. For somebody with severe pain, I'm really glad that you mentioned looking for those other life-threatening complications and thinking about how we're looking for those other life-threatening complications, right? So looking for occult fractures, looking for avascular necrosis, do we have an adequate view on X-ray? Do we need to pursue further investigations? But in terms of additional pain management, I know certainly my colleagues in internal medicine looked to our specialists in pain management. So we're fortunate at our hospital that we do have a pain service that can offer some advice. And looking at some of the other strategies for pain medications and management. So whether that means looking at other pharmacologic options like ketamine, like regional anesthesia, or are there other non-pharmacologic options that we may be able to add in that maybe have not been optimized yet? So those would be the steps that I would take, starting from the emergency department and in cooperation with the inpatient consultants in my hospital. But Dr. Cervi, I'm curious to know your response as well.
Thanks, Dr. Bryan. I think I think you touched on everything. I similarly phone a friend because I'm a hematologist, so I'm not a pain medicine expert. So I do look to our colleagues in the acute pain service in our hospital. I will say sometimes it can be a bit of a matter of ensuring that patients actually have access to what's being prescribed, and that's been sort of a bit of a barrier to good provision of care in our hospital that we're trying to tackle and break down. Is that sometimes patients aren't actually getting the medications that are prescribed to them as frequently as they can, and it has to do with some of the misperceptions or misconceptions that Dr. Bryan spoke about earlier. So ensuring that the pain regimen that's available is being used in an optimal fashion, ensuring that we are making use of the adjuncts that have been discussed, ensuring that we're not missing an acute complication that warrants potentially something like directed antimicrobials or possibly even sort of surgical management. I have to say personally, I reserve any form of transfusion therapy for a pain episode that's running into sort of hemodynamic issues. And so, we have instituted a red cell exchange for somebody who, was in such a bad crisis, and they did have some implications from a hemodynamic perspective. But that's usually sort of my approach to those challenging situations.
Well, thank you. There's a question here in the Q&A. So is there a role for apixaban in painful crisis management or in prevention? I guess that would be low molecular weight heparin. I'm not quite
It's
familiar.
a direct oral anticoagulant.
Direct oral, okay.
So a DOAC. Yeah. It's so commonly used for DVT, for PE, for other venous thromboembolism. It's not something that I've seen in acute care. And Dr. Cervi, I don't know if you have any information on that.
Yeah, it's a great question. So I've not come across any data or literature to support its use for a pain crisis, but it does sort of bring up a really good point that especially when we have patients admitted to hospital, we don't forget about VTE prophylaxis. And sometimes for adults with sickle cell disease, it's a younger patient population, and sometimes that can be a bit neglected, or there can be some oversight because there's this perception that they're young and they're otherwise healthy, and maybe we don't need to be as concerned about VTE. But we do integrate low molecular weight heparin for prophylaxis for any admission for sickle cell disease. There has been some study looking at the DOACs in a prophylactic setting in general for medical inpatients and upon discharge, but usually the benefit risk balance does not favor use of the DOACs in a preventative fashion. So it's mainly been low molecular weight heparin for prevention.
Thank you. Yes, okay. Now, there's another question on the non-pharmacological therapies. Now, in your experience, which of these non-pharmacological therapies are you familiar with that have, proven to be effective? Somebody's talking about breathing techniques, biofeedback, hypnosis, massage. What's been your experience?
The one that I'm most familiar with is cognitive behavioral therapy. I think there's good evidence in the literature for CBT. And so that approach about reframing the ideas and perceptions around pain has been shown to be very effective. I don't know the literature around the other modalities that you mentioned, so hypnosis, massage, but honestly, they seem like they would be very low risk. And if someone finds them beneficial, I think that's fantastic. I think go ahead and you know, if there are low risk interventions like that that are helpful, I don't see any harm in giving them a try. But if I was looking at, you know, if you had options for which of the interventions to fund, I think right now funding interventions around cognitive behavioral therapy as a non-pharmacologic would be your best bet. Dr. Cervi?
I agree. So I have to say there's not a lot of literature looking at different non-pharmacologic therapies, although as Dr. Bryan mentioned, probably there's a bit more for CBT as it's been studied in other patient populations. Although, guidelines, for example, the NIH, do recommend the integration of non-pharmacologic therapies for pain management, but there's not necessarily a robust study to know what the ideal type and when to actually use it is. I think anecdotally, something that I would say just in talking to some of my own patients, I think having peer support and group support, especially on the inpatient side, can be so helpful because some of my patients have said that they do feel a bit isolated when they're admitted with these pain crises, because again, the demonstration of pain is different than maybe what the hospital system is used to. And so having people with lived experience that have gone through what patients who are admitted are going through, I think could be a wonderful source. And we do, thanks to the efforts of Lonray and the Sickle Cell Awareness Group of Ontario, we do now have access to a patient well-being coordinator, and that's a resource that we're going to be using not only in our outpatient setting, but also in the inpatient setting as well, so that at least it's a source of familiarity with people who are admitted with pain crises.
Thank you. Now, Dr. Cervi, would you spend, maybe a couple of minutes to address the issue of chronic pain in sickle cell patients? What do you think contribute to it, in your own opinion? And what are your ways of, tackling it in terms of management?
Yeah, that's a great and complex question. So, personally, we do have partnership, and there was a bit of a question earlier on in terms of collaborating with other hospital settings. So we do have partnership with colleagues down the road in London, and fortunately, although we don't have them locally in Windsor, there are some excellent pain management clinics in London that are more geared towards addressing chronic pain, because sometimes there can be a little bit of this unfortunate feed-forward cycle where with more pain comes more opioid prescription, and that can actually lead to a bit of that hyperanalgesia, and that can actually precipitate more perceptions of pain. And so we want to be generous and make sure that we're offering what can be done to address pain, but sometimes upping the dose of the opioid isn't necessarily the answer. And so that's where there's integration of other adjunct therapies that aren't as effective in an acute setting, but things like SNRIs or selective serotonin and norepinephrine reuptake inhibitors that do act in different parts of the pain pathway to help modulate the perception of pain. And then ensuring that we're doing everything we can to address, if possible, potentially a surgical cause of chronic pain. And so some patients with avascular necrosis of the hip, ultimately you do work closely with your orthopedic surgery colleagues, and there does need to be some sort of surgical revision that's undertaken. Or, if there's been a prior surgical revision, sometimes the prosthesis can become looser. So, going after something that can be more easily addressed that's contributing to that chronic pain. But I think that it does need a bit of a multidisciplinary approach, and I think that's where sort of collaborations with outpatient pain management clinics can be quite effective.
Well, thank you. Yeah, talking about collaborating with other settings and other specialties. Which are the specialties that you or when you have a multidisciplinary team, who are the kind of people that you want in that team, and what are the other services that help you or that you're in contact with on a fairly regular basis, including mental health,
Yeah, so I would say in our clinic setting, so we have our nurse who's quite excellent, who's new to the role, and I think consistency and somebody to sort of frequently touch base with patients in the outpatient setting is key. We have a social worker who's also excellent to help with some of the sort of practical and day-to-day implications that sickle cell disease can pose, sort of in the workplace setting, also in a bit of a supportive and counseling role too. We have our patient well-being coordinator who also comes to our clinics when they're dedicated for sickle cell disease, that helps to put patients in touch with other resources that are available. So for example, I reference SCOGO because that's our huge Ontario advocacy program for patients with sickle cell disease, and they have emergency relief transportation funds for patients who have a difficult time getting to and from appointments, and sometimes that really does pose a practical barrier. I would say in terms of other medical specialists, we do have that relationship with outside pain management and outside pain clinics. Orthopedic surgery is another clinic that we're often collaborating with, and sometimes our colleagues in respirology as well for management of things like pulmonary hypertension, because that can be a complication of the disease long term too. And then we do have some shared patients with our partner tertiary care center, and we meet regularly every 3 months to review and to ensure that we're sort of optimizing all resources and testing that we have. So I would say on sort of my day-to-day, those are the people that I'm mainly keeping in touch with in the outpatient setting.
Thank you very much. There was a question, and I think Dr. Cervi addressed that in the chat box, in terms of what information would you advise a patient to carry with him or her when they're traveling and they're outside their usual area of care? I guess they should have a clear diagnosis that they have, their usual treatment plans, and if they already have an individualized pain management protocol, or what else would you advise?
I can speak to what would be the dream for somebody coming into the emergency department. I often see folks who are traveling who don't actually have very much information about their care. So who tell me, I get transfused once a month. I don't know why. Right. And so certainly being very clear on your own diagnosis, being very clear on the kinds of complications that you've had, because that guides treatment, right? As well as the names and doses of all of your current medications, and including if you've had any recent changes to your medications, the type and timing of any big procedures that you've had. So any surgeries that you've had, when your last transfusion was, and the name and information of your care providers at home, so that there's some way for us to get some additional information. Those would be, as an emergency physician, those would be my dream. If you came in with those things, I would love to see them. Dr. Cervi, anything to add there?
I agree. That would be the dream. And the only additional piece that I would add would be, we're trying to advocate for extended red cell antigen typing for people with sickle cell disease to prevent the risks of alloimmunization, which we know are more common, especially in North America. And so that piece of information would be exceptionally helpful too, because if we do need to work towards transfusion therapy for that patient, we want to make sure that we we are providing them with the best possible matched blood. And I think to piggyback on that too, we are, trying to do this more at our own center, is having individualized patient pathways for pain. And so some people know exactly what works for them when they need to come to the emergency room. And I think that's our goal, is to have that for every person. And if that's something that you also have on this wish list when you show up in the emergency room, that would help, I think, us provide more tailored and more specific care.
Thank you. There's one question for Dr. Bryan. Do you know if standardized order sets guidelines have been established or adopted by the NIH for sickle cell disease?
Thank you so much. And I think that was a question from Jimmy in the
Yes.
In the list there. So I typed a brief response. I don't know is the answer for the NIH. I know that in my province, in Canada, in Ontario, that Ontario Health is working to create a shared order set that can be a reference provincially. I've put my email address in the chat as well. I'm always happy to share the order set that we use in my hospital. There are some updates coming to it shortly, but if there's anyone who's interested in having a look at one sample of an order set in an adult setting, I'm more than happy to share.
Thank you so much. Well, I think we're coming to the end of this session. I would urge that people just scan through the chat and the Q&A boxes. There might have been one or two responses that would not, or questions that we've not covered. And I'm sure either of the speakers will be glad to, receive emails or whatever else or questions from you. And I think this has been a very exciting and enlightening panel session, and I really want to thank the two speakers. You were both excellent, and we all learned a lot. So thank you so much. And I thank the attendees for their participation and lively questions. Thank you so much.
Thank you so much.
Thank you.
Hello. Hi, Michael. Hello. Eka sabi rọ̀lẹ́ dẹ̀ ni.